So we're going to talk about where we do have evidence for ultrasound for spine procedures. So this presentation's about facet injections. More so, it's actually about the branch blocks, and more so about the cervical spine. I have no new disclosures. So there's a consensus work group. This section of this work group is still not published. A couple of the sections on this work group have been published in regional anesthesia and pain medicine, but this one on epidural steroid injected risk has not been published. However, it's important because it does reference ultrasound injections in the spine briefly. And in this work group, again, this is unpublished data, so this is not final, it's not peer reviewed, but their statements include that ultrasound guidance does not involve radiation exposure, does identify neurovascular structures that are not visualized with fluoroscopy, and it can estimate the distance to your target for an injection, for an epidural injection, and that level of certainty is high. Indian physicians experienced in the use of ultrasound, this goes back to Christine's comment about physician experience does matter, the safety and effectiveness could be similar when using ultrasound or fluoroscopy for an extraforaminal cervical nerve block. Okay, so not an epidural steroid injection, we're talking about outside the spinal canal, a nerve block. Okay, the level of certainty of this is low. And so the recommendations, again, still not published or peer reviewed, are that ultrasound, when appropriate, could be considered to supplement other imaging, such as fluoroscopy, such as a hybrid approach, to decrease radiation exposure, and that level of evidence is grade B. And ultrasound guidance is valuable to identify neurovascular structures for the performance, again, of an extraforaminal injection, and specifically in the cervical spine. And that level, that's grade B. Okay, so this talk that I'm giving is mostly about cervical medial branch blocks and not pertaining specifically to epidural or nerve blocks, but I think this is something you guys need to be aware of, that as many societies convened on this, there is some agreement that we can use these in certain situations. So, ultrasound validation studies with fluoroscopy or CT don't look great. Cervical medial branch and cervical peripendicular injections, when you try to validate them with fluoroscopy, aren't great, and there's a lot of controversy, and that's kind of what Christine already pointed out. And so many of my colleagues, especially in the United States, say medial branch blocks under ultrasound, you don't need to contrast, it's just not accurate enough. And as Christine also pointed out, can you visualize the proper vertebral segment, in the cervical spine especially, it has a lot of error the way it has been done in a lot of these studies. Again, without a standardized technique, there's flaws. Okay, so however, in order to really evaluate the evidence, we have to look at this in a systematic manner. And the cervical medial branch blocks with ultrasound guidance have the most evidence. And so we're going to talk about that and how that should guide us at looking at injections at other targets as well. So back in the early 2000s, we first looked and said, okay, we can see the third occipital nerve under ultrasound, and we can correctly anesthetize the third occipital nerve 90% of the time in normal subjects. Okay. So, but that says, okay, great, we have something to go on. And so then they said, okay, what about the rest of the cervical spine? Well, in C5, 6, and less so at C7, you could also visualize these medial branch nerves much of the time. You can actually see many of them under ultrasound. And this study looked at, well, can you correctly place the contrast on these medial branch nerves and verify that with fluoroscopy. And they use what's called an out-of-plane technique, and this is important as we move forward. So the technique that they use, just like when we do fluoroscopic studies, you need to know, okay, they are not accurate all the time, what technique do they use and how can we improve that? So they had correct needle placement at the medial branch 77% of the time in general. Third occipital nerve was much more accurate, right? So that's more superficial, it's easier to see. C7 was not so accurate. It's a more, it's a deeper structure, it's more difficult to read out. Coverage of the target with the contrast was better, right? It might not be exactly in the perfect place, but you get coverage with the contrast 84% of the time in this target, in this study. So this is kind of how it would look on a coronal view. And this is a panoramic view where you can see the whole spine. This is not typical, not every machine has this capability. Hence the problems with documenting what level you were actually at. But in this out of plane technique, you have the transducer in plane with the articular pillar, and then your needle shows up just as this little dot, right? And where your needle tip actually is can be confusing, right? So this is a problem with accuracy. So then another group out of Canada, Finlayson, described another technique, coming in plane, where you can see the whole needle, and you're looking at the vertebral segment in transverse view. And they showed that you had proper location almost 95% of the time. Okay. And there was some aberrant spread some of the time, and we'll get into that as well, but compared to fluoroscopy. And this is the technique there. So you can see, so on the left side would be dorsal, so your lamina would be here. This is the articular pillar. It's the waist of the articular pillar. Here's the needle as we visualize in the in plane, and you can clearly see the bevel of the needle. And this is the depiction of what we're looking at here. Here's the posterior tubercle of the vertebra. So you're visualizing the whole length of the needle. The other thing is the way they counted. They counted from the top of the cervical spine. Counting from C2 down is more accurate under ultrasound. And so they were accurately getting the correct vertebral segment when they verified it on fluoroscopy as well. But as pointed out by Dr. Sadell yesterday, one view is no view, right? So why would we be studying ultrasound procedures in a single view? We don't do that with fluoroscopy. So Finlayson's group did biplanar study. So they describe a biplanar ultrasound technique. And this first study was at C5 and 6, and using a low volume of contrast and local anesthetic. And C5 was 100% correct compared to fluoroscopy, and C6 was nearly 100%. So now we're talking, right? So this is, okay, now we're comparing more directly a biplanar fluoroscopy technique with a biplanar, or 2 views in fluoroscopy and 2 views in ultrasound. Now you get comparable results with a standardized technique. You go, okay, well, great, what about, how do you do this? So you drive it in plane, just like in his first study, and then you verify out of plane, okay? So you have 2 views, so and here, you don't have as much error because you drove it in plane, but again, you have that dot here that you saw where the needle tip was in the other view, okay? So you go, okay, what about C7? Well, Finlayson's group then described C7 with a biplanar technique as well, and also, as is in the IPSIS guidelines, blocking multiple potential targets, right? So we don't, with C7 medial branch, we don't block just one spot, you block 3 spots. Okay, so they blocked more than one spot with ultrasound, and now at C7, the success rate was 92%. And fluoroscopy still was not 100%. You can't always get the flow to be exactly right. So it's not perfect at C7, but it is, again, closer, using a biplanar technique. Well, what about the accuracy of fluoroscopic guided medial branch blocks? Right? So this study by Cohen and colleagues looked at cervical medial branch blocks under fluoroscopy compared to the gold standard of CT. Okay? And they were really looking at accuracy with different volumes. So a cervical medial branch block with 0.25 cc's of contrast and anesthetic mixed together versus 0.5 cc's. Okay, so which volume is better and how accurate are both of those on fluoroscopy compared to CT scan? And they showed an inaccurate block occurred up to 64% of the time. That's really, really bad, right? So my colleagues who say ultrasound is not accurate, I look at this and go, well, neither is your cervical neovascular under fluoroscopy if you look at CT scan, right? And if you look at the comparison between 0.25 and 0.5 cc's, the aberrant spread was obviously much less when we use a lower volume, right? So this speaks to the fact that when we do our branch blocks in the cervical spine under fluoroscopy, we should be using 0.25 cc's, right? We get adjacent spread too frequently with the 0.5 cc's. And the number of nerves missed is still 7% on fluoroscopy when you compare it to CT scan. So what this is telling me is ultrasound is just as good as fluoroscopy. Unfortunately, we don't have an ultrasound, fluoroscopy, and CT study yet, right? So we don't have both of those modalities compared to CT scan under the same operator. And so hopefully that'll be done in the future. Dr. Stoviza and colleagues looked at these techniques on a cadaver, or 5 cadavers, and they placed the needles under ultrasound using 3 techniques, either the out-of-plane coronal, the first one that I showed you, the in-plane transverse, the second one I showed you, so both of those are not 2 planes, just 1 plane, and then a biplanar Philipson technique. Okay. And what they showed that there wasn't a difference actually when they did it between those techniques compared on fluoro. So this goes back to saying this is very operator dependent, okay? And probably patient or specimen, this one, cadavers, but dependent on the specimen you're looking at as well, because sometimes when you look under ultrasound, you go, this is very confusing. And so they said, well, there's not really a difference, and they were all in that 70% range of accuracy when you looked at fluoro. Now, again, they did not look at it under CT scan to then say how much of the fluoro was correct. And then they also looked at potentially dangerous placements, and this is important. And the one technique that resulted in potentially dangerous placement next to the nerve root and the vertebral artery was that out-of-plane technique. So if you learn anything from today and nothing else, it's do not do a cervical medial branch block with an out-of-plane technique that can result in catastrophic injury. Okay, so just like on fluoroscopy, we want to avoid those techniques that are dangerous. So don't use a single out-of-plane technique in the cervical spine. The in-plane technique did not have any dangerous placements, and neither did the biplanar technique. Okay, so those are reasonably safe. And this is just an example of the needle placements on the Stoviza study from last year. I'm not going to go into cervical facet intra-articular injections in detail. This is just for your reference. It just doesn't teach intra-articular steroid, but you can access the facet joints under ultrasound as well in the cervical spine, and you go in-plane posteriorly, and again, using an in-plane technique with visualization of the needle, you can drive the needle in the joint. The problem is, again, you cannot see the contrast spread to verify it is intra-articular, so you can't really verify it's in the joint. That has been verified by Naruse and colleagues. All right, but there, like I said, there is risk. Okay, and this is a case report of a spinal cord hemorrhage at C7T1 after a C7 needle branch with ultrasound guidance. But it doesn't describe what technique was used. So if this was out of plane technique, I go, okay, I can see how that could happen. We don't know what was injected. Why on earth would you get a hemorrhage in the cord if you were just injecting anesthetic? So what we inject is important as well. So we should only be using particulate-free, preservative-free substances, correct? In the cervical spine, especially. And there's lots of techniques to avoid this, right? So I just described them, so, there's ways to avoid injury, as is the same with fluoroscopy. So these images are from my colleague and mentor, Dr. Dreyfus, and this is a spinal cord injury as a result of an attempted third occipital nerve block under fluoroscopy, right? So it doesn't matter what technique you use, you're in the cervical spine, and there's a risk of catastrophic injury. You have to use a standardized methodical technique and always be thinking of the potential hazards. No matter if you're using ultrasound, CT scan, or fluoroscopy. So for the cervical spine, for medial branch blocks, we still can't save and document what level we were at. So I can't save an ultrasound image of my procedure, and I can't look at it, or my colleague can't look at it, 2 weeks, 8 weeks later and say, that was C4-5. You don't have all the levels lined up as you can with fluoroscopy, and that's a problem. Obviously, if you can't see the needle tip, it could be in something that's very important, such as the cord or the vertebral artery, and you can cause catastrophic injury. And standardized technique is really important. So we have to, like we said, one view is no view. Biplanar is the way to do it to be accurate and safe, and we need further studies with this more accurate and standardized technique with low volume injecting. And we need a validation study with CT scan is what we're going to need to compare it to fluoro more directly. And then of course, clinical outcomes in the end. All right, what about lumbar spine medial branch blocks? IPSIS does not teach in the medial branch blocks in the lumbar spine with ultrasound guidance because it is more challenging. As soon as your BMI increases, it's already a deeper structure and more difficult to visualize with ultrasound, but it can be done and has been documented. And so these are for your reference. I'm not going to go into them in detail, but so you can look them up. And this is to just drive home the point that when you have a BMI that's higher, your accuracy on these medial branch blocks is challenging. So the success rate was only 62% as determined by fluoroscopy when the BMI was over 30 when attempting to do lumbar medial branch blocks with ultrasound. And this is the documentation of a technique that is bioplanar that one could use. Okay, so you visualize an ultrasound with the vertebra in transverse. Okay, so you'd be driving the needle in plane from lateral to medial. Here's what it would look like on ultrasound. Okay, so you have the transverse process and the junction of the transverse process with the SAP here. This is your target. And then you drive your needle from lateral to medial to the target. And then you would verify in another view, right, by planar. So you change the orientation of your ultrasound probe, and then you would want to see the dot of the needle tip. And this one is incorrect, right? So you want to see it on bone, and so you want to see it more in this area. This is the transverse process. You want to see it here, and this is up, so it needs to be repositioned to be accurate. So in summary, these, fluoroscopy and ultrasound are different imaging modalities, and we have to understand the limitations of each one, and each one has advantages. And so the utility of using ultrasound really depends on these specific circumstances. First off, your experience using ultrasound, and I'll go into when I talk about SI joint, using a hybrid with ultrasound and fluoroscopy really improves your knowledge and improves your technique. And being able to visualize the target anatomy with ultrasound is important, so much more utility in the cervical spine where everything is more superficial than in the lumbar spine. And understanding the limitations of using different trajectories and really coming up with standardized techniques is important. And then, of course, region of the world and socioeconomic status factors matter, right? So in the US, we have easy access to fluoroscopy, but in other regions of the world, ultrasound may be something that we want to rely on more, just because of the factors of availability. And so in the future, we will move towards requiring the standardized techniques and comparing, so fluoroscopy and CT scan especially, and always, 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 no matter what we're using, respecting the limits of our imaging technology and understanding risks and complications.